Well, thank you. What a great pleasure and honor to, again, share this podium with some eloquent speakers and wonderful people. So again, I want to thank Jim for inviting me to this spectacular event. I think we all agree. And thank you, Joe, for your vision and leadership and getting us to the point where we'll see zero preventable deaths. But we're starting to be concerned that in 2020 or earlier, if we reach that goal, that's half the journey. And we need you to lead us to the second half, which is hardwiring this, that we'll never see preventable deaths again. So I'm actually going to go back to the previous slide, if you don't mind, but I'm here again as a commitment from Englewood Hospital Medical Center. I hail from New Jersey, as you know, exit 71, to again share the commitment. I just want to say a couple of words about the hospital. We have a culture. In the last 4 years, we received an A grade from the Leapfrog group for patient safety. That's consecutive 4 years. In the last 2 years, we've abandoned percentage. We're counting infections, whether they be bloodstream or catheter-related urinary tract infections, in numbers, using 0 and 1. So again, we are committed to this patient safety. I would like to again address with you an epidemic today. And this is a silent epidemic. And I'm grateful to Joe, Jim, and the rest of the board for giving millions of patients who have been silenced by this epidemic a voice. And that voice has to do with anemia and transfusion. On this slide, you see 3 organizations. One is a commitment from today, another one has already committed, and a third will commit, I guarantee. So we're talking about transfusions and we're talking about anemia. And the question is why transfusion is a patient safety issue and why is anemia a patient safety issue? And I'd like to address that with you. Those of you who saw the Wall Street Journal op-ed page a week ago, now as you know, Wall Street Journal is one of the more prominent medical journals that we have. You see Tim Hannon and et al. And what they did is they titled this Saving Blood, Dollars, and Lives. Everything has to look from the economic side, of course, in the Wall Street Journal, but there's some very important information that was written into this op-ed page. And you could see that transfusions are great when they're used appropriately, but too often they're not. The other issue is that blood used capriciously results in patients' injury and death. That's where we have to talk about in terms of preventable deaths. After 1999, there was, again, an article looking at liberal versus restrictive transfusions. We have actually known since then, there have been many publications showing that more is less. And again, I'm sorry, that less is more. And that thousands of articles show association between blood transfusion and a variety of adverse outcome. So if it's unnecessary or if it's not necessary to give a unit of blood, all we're offering patients, again, is the possibility of injury and harm. The doctors who follow the old ways use 30 to 50% more blood than their peer. And we know that the Institute of Medicine already talked about this yesterday. There's a 17-year lag between the bench and the bed, meaning in terms of research and clinical practice. Unfortunately, it takes more time for our regulatory agencies to change some of the rules that they have to, again, become modern and relate to what we know today in terms of how we should treat our patients. We need to change that too. In this article, transfusion again, they looked at the Nabocus, which as you could see on the left side is the National Blood Collection Utilization Survey. You could see that blood, again, about 21 million units of components have been transfused. About 15 million of that is red cells. Conservative estimate that between 6.5 to 10.5 million transfusions are necessary. You could see the cost issue. And at the bottom, you see that the overall unnecessary costs cost healthcare about $40 billion a year, twice, I think, of what sepsis costs, although there are probably some dollars from sepsis there. Using the National Surgical Quality Initiative data, reducing blood usage by 30% can result in repurposing of 12 million nursing hours, annual reduction of 200,000 wound complication, 8 million fewer patient days in the hospital, and as many as 50,000 lives saved. That's 25% of the 200,000 that we're trying to change. Okay, so who's at risk? Again, we know that blood, if used appropriately, amongst other things, stopping the bleeding and other intervention, it could save lives. We see that on the left side of this diagram. On the right side, though, some patients have immediate injury. That is a hemolytic reaction that could be fatal. And in the middle is the most prevalent population receiving transfusion, which are hospitalized patients who receive between 1 and 3 units of red cells transfused. If we cannot demonstrate any benefit of that transfusion, all we're offering those patients is risk and cost to healthcare. You can see again that the Joint Commission, in conjunction with the American Medical Association, PCPI, which is the Physician Consortium for Performance Improvement, in 2011 had a national summit on overuse. These are 5 areas where, again, if we can't demonstrate benefit, overuse is defined as just giving patient the risk and the potential for harm. You could see 5 of these, of which one of them has a blood transfusion on it. And again, there's a white paper that was published as a result of this meeting. Those of you familiar with the Choosing Wisely campaign, and we're not going to debate how wise it is, just to show you that there are multiple professional organizations that have looked at this issue and again are all commenting on the fact of overuse and that restriction of transfusion clearly helps patients and reduces injury. Now, there's another issue of culture. There's good culture and there's bad culture. And when it comes to transfusion as a culture, we're looking at bad culture. This is just one of many data out there to show you that transfusion is variable. There's variability in transfusion from institution to institution and from practitioner to practitioner. This is just data in coronary artery bypass surgery, but we have data in other surgical conditions as well as medical conditions with the same picture. It's interesting that the variations in transfusions, again, as you could see, are due to local culture and physician preference, not a science. This, again, is a culture and not a good one. Now, many say, well, my patient needs to be transfused because they're sicker. The data again and again demonstrate that variability transfusions are not due to the differences in patient's acuity. And they're not generally different from those who've not been transfused. Again, it refers to the culture. As you could see, these variations are due to patients, how blood is managed, anemia treatment, avoiding blood loss, inappropriate transfusion threshold. Now, I'm not going to talk to you a lot about the infectious risk, but we remember yesterday the discussion about Ebola. We have made, again, strides in terms of reducing the risk of envelope viruses and other agents. But as you could see, we don't test for everything. The fear of all of us is that a new agent gets introduced into the healthcare system as well as to the blood system and gets transmitted by transfusion and ends up with patient injury, especially if that transfusion is not necessary. It is the non-infectious risks that are the ones that are giving us some of these issues which are associated with negative clinical outcomes of patients who get transfused where it's not needed or not necessary. And it just shows you that if you believe that blood is an organ, then transfusion is a transplant, and clearly that transplant has implications to the immune system of the recipient. So let's look at some of the data in terms of the clinical outcome. These are friends in the UK. These are all transfusion specialists, and what they did is they looked at population studies because the criticism is that population studies are not randomized control, therefore we should take them with a grain of salt. But you could see again, these are large studies. They identified considerable variability in patient population, study design, as well as statistical adjustment. But when they cleaned it all out, when they cleaned all these variables out, even these transfusion specialists show that overall observational studies do show a consistently adverse effect of RBC transfusion on mortality, not to say that it doesn't affect morbidity. This is on patients, again, who probably do not need to be transfused. And this is the data. Again, you could see that at the end, the composite, depending on where the origin of the trials, are all pointing to the side of harm. What about randomized control trials? Again, looking at this Cochrane review, you could see they looked at 19 randomized controlled trials, over 6,000 patients, comparing restrictive versus liberal transfusion. And here they did look at multiple populations of patients, and you could see the walks of these patients where they came from: cardiac, vascular, orthopedic, and other medical conditions, including intensive care unit. Restrictive transfusion not only reduced, again, the restrictive approach not only reduced transfusion by 40%, but also had a significant impact on morbidity and mortality. Now, this study came out early last year in 2014. And here what they did is they looked at restrictive transfusions where the transfusion threshold was less than 7 grams per deciliter, very restrictive. And you could see that although they looked at relative risk, the risk in the restrictive group was reduced for both hospital and total mortality by close to, again, 26%. You could see that rebleed in upper GI bleed patients, the restrictive transfusion reduced their risk of mortality by, again, close to 26%, a greater than 50% reduction in acute coronary syndrome, a greater than 50% reduction in pulmonary edema, and a 14% reduction in bacterial infection. We're all, again, addressing sepsis. So why are patients being transfused? We know that there are 3 reasons for that: anemia, blood loss, and the culture of the transfuser. So I'd like to, again, move on and show you that there is data out there where we show that 94% of transfusion of surgical patients can be attributed to low preoperative hemoglobin level, anemia, excessive blood loss, both surgical as well as phlebotomy, meaning blood tests, and inappropriate transfusion practice. Talk about preventable. These are all modifiable risks, but we're silent on this issue. And again, the problem is that I talked to you about transfusion. Transfusion is a therapeutic intervention. We need to know what the underlying disease that we're treating. And this underlying disease is an epidemic. And this epidemic has been silent until this group has given it a full voice. So again, you could see that the problem is anemia. It's not just what hemoglobin to transfuse a patient. Anemia is a global issue, a hospital issue, an ICU issue. What is the issue? The issue is that we make things worse by phlebotomy, and then, as I already showed you, we add more risk to these patients once we make them anemic or ignore the anemia with transfusion. And I'll talk a little bit about the answers. This is the patients that we represent. You could see close to 2 billion people across the globe suffer from anemia. 25%, as you can see, of the world population is anemic. The highest prevalence is in preschool-aged children, close to 50%. The group with the greatest number of individuals affected is non-pregnant women. No longer can we remain silent on this issue. Anemia, unfortunately, is accepted as a normal part of doing business by many of my colleagues. Although that's changing, and I think this group is going to make even a bigger change. We have a long tradition of accepting anemia as a relatively harmless problem that can be corrected easily with a transfusion. Convenience, all convenience. For the medical community, transfusion as treatment for anemia remains a default position. The new paradigm is that anemia is an independent risk for morbidity and mortality regardless of the level of hemoglobin. We just need to screen and make that diagnosis, and transfusions compound the problem. Go back to your hospitals. Does anybody here know what is the prevalence of anemia in your hospital? This is data from 10 hospitals in the United States. You could see close to 200,000 hospitalization. 3 out of 4 patients in our hospitals are anemic. And you could see that as their hemoglobin level goes down on top, that the relative risk of mortality, length of stay, and charges increases. 3 out of 4 patients. And those who come in who are not anemic, I will tell you, we guarantee that we'll make them anemic. Because there is something called ICU vampirism. That is, we have an issue of drawing blood. The most common reason for phlebotomy of patients in U.S. hospitals is sunrise. It's a tradition. Those of you who've been in the hospital know that they come in the morning. And they take an average of 40 ml from each patient. That's more than you can make as healthy individuals. Imagine the sick patients in hospitals. Excessive blood draws in the ICU lead to transfusion, compounding this problem. We've got to change the culture. Again, you could see that the volume as well as non-routine phlebotomy helps. This brings me to one answer. The answer is patient blood management. This is a cultural event. The definition is the timely application, which means we got a plan. Talk to each other, work together. It's a timely application of evidence-based medical and surgical concepts designed to manage anemia. This is now patient-centered. We're not talking about transfusion. We're talking about a disease or a condition. Optimizing hemostasis, another patient-centered event, and minimizing blood loss in order to improve patient outcome. This requires breaking the silos, working together. This is a multimodality approach. And again, it's not a blood product focused, it is patient focused. This is the four-leaf clover that describes patient management. Behind each one of those leaves, there's a list of things that we could do for patients to prevent these conditions. Transfusion is on that list, but not on the top of the list. It is all the way down once everything else has been exhausted. So we are asking today, we look retrospectively, was the transfusion appropriate? But the correct question is actually, was it avoidable? Just like these issues we're talking about today and yesterday. And the answer is that it is, with change of culture, with patient blood management. So Aaron yesterday called for action, and I call for action too. We have to eliminate anemia. By eliminating anemia, you could see that we can make the world a better place. By eliminating anemia, we can also reduce patients' exposure to transfusion and allogeneic blood. Thank you.